Apraxia and neuronal linkage. Imagine asking a person to wave his hand to say goodbye. He understands you. Uh, his arm is not weak, but he cannot perform the movement correctly. This is apraxia. In apraxia, the brain loses the connection between the motor intention and motor execution. Damage to parietal lobe, premotor cortex, supplementary motor area, basal ganglia, or corpus callosum disturb the neuronal network uh, for the execution of the planned movement. Hi, my name is Dr. Wes, and today we're going to discuss apraxia and neuronal linkage. The patient have the or person have the intentions to move or plan for motor plan for the movement. The plan get blocked and there is no movement. On the other hand, the person without any apraxia or brain injury can easily plan and define his movement. Apraxia is the impaired execution of learned purposeful action despite preserved strength, sensation, and comprehension. Inability to perform learned purposeful motor task, that is the apraxia. It is not a primary weakness of muscle strength or reflexes. Strength is there, tone is there, and reflexes are there, but there is no movement of the hind limb or forelimb. Command, intention, motor schema, execution, and action. There are a few reasons why a person cannot move accordingly or according to his plan. The reasons are few but important: stroke, trauma, tumor, dementia, or degenerative diseases. Pathogenesis: brain lesions due to stroke, trauma, tumor, or dementia causes a major problem in the brain. Dominant parietal or frontal network injury. Stored motor programs inaccessible. There is no memory, incorrect gesture or posture or sequence. Lesion sites should be evaluated. Cognitive motor failure and behavioral outcome should be monitored by the physician and medical staff. Parietal motor memory, premotor plan, SMA sequencing. There are two types of SMA: sensory motor area and spinal cord sequencing area. In some cases, there are spinal cord sequencing, so the term is used to define that. Motor cortex and muscle intact. That is the blockade area where the network get blocked and there is no movement. Mechanism of disease: intention, motor concept, or pre-plan motor movement or muscle movement. Execution: that is blocked or due to block of this execution there is no movement. These are the error types. Automatic actions may sometimes be better than the command-based actions. Speech apraxia is very important, planning of mouth movement, and sometimes the patient have the speech apraxia. He want to say words he planned, but he cannot do so at that time of moment. That is the neuronal linkage, inferior parietal lobe, and motor memory, premotor planning, SMA sequencing, basal ganglia, and cerebral timing. That is, regions are involved in the plan movement. Apraxia emerges when communication between these areas breaks. Type of apraxia: ideomotor, ideational, conceptual, lem, buccofacial, apraxia of speech, constructional, and gait apraxia. These are the 8 types of apraxia. Gesture error, tool use error, sequencing error, speech error are the major errors that are showed by the patient uh, having the apraxia disease. Diagnosis: beside apraxia testing, uh, the patient have to ask to do some tasks like combing hair, using scissors. That is the excluding the mimics, tone, succession, coordination, language comprehension. Uh, Neurophysiology: common task, imitation task, tool use task, ADL impact, and imaging. CT and MRI are used to do the imaging to evaluate whether the patient have previously go through the infarction, hemorrhage, trauma, atrophy. Speech and language evaluation for apraxia of speech. Treatment: stroke prevention, rehab, tumor, occupational therapy, speech therapy, safety. These are the important therapies that are used by the physicians to rehabilitate the patient. Assessment for functional deficit: break task into steps, small steps. Use cues and plus repetition in the patient with dementia or having lesions in the brain. Practicing the context and improve ADL safety. Prognosis: good prognosis if the uh, before the apraxia, the patient may have the trauma, atrophy, degeneration diseases that could be diagnosed, and starting the therapy before starting the therapy for the apraxia. Variable prognosis: moderate lesions, mixed aphasia. Guarded prognosis: acute lesions is the major important part present in the 70% of the patient with apraxia. Rehab, task practice, adaptation, and functional outcome. That is summary. Brain lesion plays the most important part. Access network break, motor plan failure, purposeful actions fail, and the outcome of this disease, and with the therapy of rehab plus safety execution of the task. The most important thing in this discussion is the uh, network failure in apraxia, and that is due to corpus callosum, basal ganglia, cerebellum, premotor, SMA. These are the regions in which the lesions can generate after the stroke or atrophy or trauma, and that can follow through by the apraxic disease. That is the graphical summary. So you can easily understand what is apraxia and the neuronal linkage, and how motor planning disorder is intended in the patient and intact. Uh, Apraxia is a disorder of motor planning caused by disruption of parietal frontal neuronal network, leading to failure of learned purposeful movements.